Hey, welcome back, everybody. Making progress here, all right? Next video in our learning installment is going to carry forward from our discussion, very robust discussion, on type 1 diabetes mellitus and the general overview of diabetes mellitus, right? That video was a little longer than usual, a lot of information to cover. I'm expecting to keep this video a little bit shorter for you, a little bit more bite-sized, right? So I'm going to maybe break up the content into a couple of video uploads as to not overwhelm you with too much content per session, right? But the focus of this session will be on our other type of diabetes mellitus. That would be type 2, the two major versions. Type 1, as you recall, is all about the loss of ability to produce and secrete insulin. So the major treatment associated with type 1 diabetes is all about replacing insulin, whether it be exogenous, like we talked about, with insulin pumps or injections, or new novel therapies, that being stem cell treatments or whatever's next in the research pipeline for helping treat, cure, remedy type 1 diabetes. But regardless, it's all about replacing that missing insulin from the autoimmune condition and the immune cells and the autoantibodies attacking the beta cells of the islets of Langerhans, causing the diminishment of insulin, right? With that said, we're going to carry forward with type 2 diabetes mellitus, right? Type 2 diabetes mellitus is all about this concept of insulin resistance. All about insulin resistance, right? So if we're talking about the etiology, the causative nature of type 2 diabetes, in this instance, we have enough insulin. We have actually more than enough insulin, which we'll allude to in a moment here. So the problem isn't the pancreas being able to respond to a glucose challenge by producing and secreting insulin. Now it's the problem of the periphery, right? It's those target organs that we alluded to before. It's the skeletal muscle, it's the liver, and the adipose tissue, right? Those are the three major organs and tissues and cell types that we're focusing on for this class that seem to be very responsive and responsible for the regulation of glucose homeostasis within the body. The skeletal muscle, most predominant, right? The liver and also the adipose tissue is also really responsive to insulin. And we're going to mention that because it has a very close coupling with the adipose tissue to the metabolic syndrome, right? And issues associated with blood fats and so forth that's going to lead us into our future discussions with atherosclerosis, right? So once again, these are not independent disorders. This metabolic system is this crosstalk between these disorders, between diabetes, obesity, cardiovascular disease, right? All playing together to cause this problem, right? This perfect storm of issues, right? With that said, all right, that's the foundation. So if you think about type 2 diabetes, you're thinking insulin resistance, right? The cells become resistant to the impact of insulin, right? And as a result, we wind up with chronic hyperglycemia. The cells cannot take up and respond to the challenges of high blood sugar, okay? We'll allude to that here in a little bit in terms of a little bit in depth about the etiology, right? More cellular, you know, my arcs of death, as the students will call it. I love that, to kind of get a little bit to the underpinnings and the specifics of the condition to give you a little more meat on the bone associated with the etiology of insulin resistance. But a little bit of background, like we did for type 1 diabetes, we're going to talk about the prevalence. Right, the prevalence of this condition. This is highly prevalent, right? We talked about roughly 2 million people in the U.S. being diagnosed with and living with type 1 diabetes, right? In this instance, it's even higher for the type 2, right? So for all individuals who are diagnosed with diabetes mellitus, 95% of them are going to be type 2 diabetes. Most of the cases of diabetes mellitus, this problem of filtering the sweet, once again, is about type 2 diabetes. So they're both very prevalent, but type 2 diabetes even more so, right? How prevalent? About 10% of the population, right? And this is becoming more of a worldwide statistic, right? We're seeing it throughout all countries over in Europe and Asia, and it's really about that 10%. Certainly in the U.S., it's about that 10% of the population is living with, trying to manage type 2 diabetes. So what does that make? In the U.S., anyway, that would be about 30 million people. 30 million people, right? 1 in 10, 10%, 30 million people. So without a doubt, regardless of your clinic, you're a radiation therapist, and the students have been reaching out to me. It's wonderful. I love to hear from you. Sounds like you're all in wonderful programs. I love the dialogue. Keep doing that. Keep reaching out to me. Radiation therapy, occupational therapy, physical therapy, PA, chiropractics, veterinary. You're going to come across patients and individuals and dog owners and whatever it may be, whoever you're working with, who are living with diabetes, right? It is so prevalent in society. So I always say you're treating the whole patient, not just their knee, not this specific issue, the whole patient. And a lot of the patients are living with diabetes, type 2 diabetes in particular, right? What makes this even more prevalent is that, we're going to define diabetes mellitus here when we start talking about diagnostics, right? And what specifically to mean in terms of measurement, right? What are we exactly measuring to quantify and specifically diagnose an individual as having type 2 diabetes, right? We'll do that in a subsequent discussion. But there's another condition called prediabetes. Prediabetes, kind of like a warning flag for individuals as they're progressing. We're starting to see some signs and symptoms that are suggestive of this individual moving towards full-blown diabetes mellitus, right? And 1/3 of the population, right? 1/3 of the population is living with prediabetes, right, in the U.S., right? So what does that equate to? About 100 million, right? So 100, 130 million somewhere are living with diabetes or pre-diabetes. Like, it is extremely prevalent. That's why you're going to see all the commercials out there for all the drug treatments and the new novel therapies that are designed to hopefully help people in the management of this extremely prevalent condition, right? So 1 in 3, 100 million people in the U.S. alone living with pre-diabetes, meaning their blood sugar from a rested and fasting condition is hovering just over 100 milligrams per deciliter, right? Just outside of that comfort zone of the homeostatic range. Once again, we'll put some more detail onto that here in a little bit, but they're starting to see some problems, right, associated with blood sugar, right? A little more detail on the prevalence here. It's more germane to type 2 diabetes. So although 10% of the population, on average, is living with managing type 2 diabetes, right? We know that the country is made up of all sorts of different races and ethnicities and identities and so forth. So is it uniform across all these ethnicities and races? And the answer to that is no, right? I put up a link for the CDC, the Centers for Disease Control, that goes into a lot of detail with this, but we know across the population that it's not of equal distribution. It's not every ethnicity and race all experiencing 10% of an issue with type 2 diabetes, right? What we see, individuals who are of the American Indian and Alaskan natives, so American Indian or Alaskan heritage, native, we're seeing higher rates. We're seeing maybe upwards of maybe 12% of the population, right? The Hispanic population is higher than that 10%, right? Maybe 11 or 12, maybe 11.5%, right? Asian, about 9%, that's a little bit lower. Asian population, about 9%, right? The black population, African American population, is about that 12, 13% maybe, right? And then the white population, right? Non-Hispanic white. Let me write that in English, it'd be even better, right? Is hovering maybe closer to 8%. Is that the data that I have? Yeah, 7 to 8%, somewhere in that area. Okay? So you see, the purpose of the story is that there is disparity, right? Some are higher than even that 10%, some are a little bit lower, right? And you're all going to be working as clinicians, right? So you have to make sure, and maybe in different regions of the country or the world, you have to appreciate the region and the needs of the society in which you're going to be caring for the individuals in that community. So if you're largely living in an American Indian or an Alaskan community, you're going to have to appreciate that the rates of diabetes mellitus type 2 is going to be higher in that population. There's going to be a greater need for attention in that area, right? In certain communities, the black community, African American community, Hispanic may be a little bit different. So the overall arching thought I want to put, you have to treat the community and the society in which you're involved in. So if you're in an urban environment, a metropolitan environment, a rural environment, you're not only treating that patient, but you're going to be responsible for that community as well. And these etiologies of the various conditions are going to vary. So you have to appreciate that as a future clinician of what are the major disorders, diseases, problems within the community or in the society that you are practicing. It's not just one uniform number, but you have to really embrace and understand who are the patients in your community, how can you best care for all of them if they have special needs that are beyond just the average number, right? So just want to make sure I articulated that because it's so critically important to understand your community in which you're practicing and the society which you're practicing in, okay? Good. All right, so let's now toggle towards, just circling back a little bit, I want to kind of get into this idea of a little bit of the etiology of type 2 diabetes mellitus. Just a little bit of etiology discussion to kind of put a little more detail on this, right? So you know my arcs, right? So we have this is an etiology in more detail of type 2 diabetes. What we're really saying is insulin resistance, right? How do we cope with, manage, treat insulin resistance, right? So in this instance, the pancreas is working fine. The pancreas is absolutely working fine. So we're in this state of maybe postprandial again after eating. That was our example from last. So you eat in a meal. We know what the normal physiology, the healthy expected physiology is, right? We have a hyperglycemic challenge, right? So our blood sugar is rising up above maybe that 100 milligrams per deciliter or so, right? We don't want to store it in the blood. We want to get it out. We want to remove it. We want to get it into the liver. We want to get it into the skeletal muscle. We want the fat cells to take it up. Those are our three major target areas for glucose. In the fat cells, the average is going to convert and store that glucose as a fat molecule, as a triglyceride, right? That's the job of the fat. That's the role of the fat in our story of insulin. When insulin binds onto the adipocytes, it pulls the sugar in and converts it to fat. We have a relatively finite ability to store glucose in our body. We know the liver can store some, skeletal muscle, but when those get saturated, right, the body can't store any more sugar. What it does is we all know the adipocytes are very adept at taking glucose, converting it to triglyceride, and then storing it as fat, right? So that's one other way of getting sugar out of the blood is to convert it to fat and to store it as an adipocyte, in the fat cells, okay? So, cool, all right? So we have hyperglycemia, right? We know that was, I don't know, I can't remember my numbered system. They're going to be different every video, so don't memorize the number. Just appreciate and understand the sequence. So we have a hyperglycemic response, right? I think R2, we know my pancreas, my artistic capability of my pancreas, right? So our pancreas here is going to respond to and sense that glucose, right? And produce and secrete insulin. All right, so the beta cells in the islet, right? Islets are Langerhans, I love saying that, right? Will secrete insulin. So that still goes on in type 2 diabetes. It's not, we don't have an autoimmunity issue with type 2 diabetes, right? The pancreas is still working well, the beta cells are fine, insulin's being secreted, right? We had our insulin receptor. Our insulin receptor, once again, the insulin receptor is located on the liver, it's located on the skeletal muscle, it's located on the adipocyte. Maybe when insulin binds on, there's a different response depending upon the organ or the cell. But in general, they all have the insulin receptor, right? So in this case, the insulin is still binding to the receptor. There's still this hormone-ligand interaction. Everything's totally fine, right? Now the problem, when we say insulin resistance, right? We had our insulin-mediated cell signaling, right? Let me write that in legible fashion. Be more helpful to you, right? Insulin-mediated cell signaling, which for our molecule converged on the molecule of AKT, right? And then AKT communicated to our glucose transporter, right? And then our glucose transporter migrated to our cell membrane, docked itself in the membrane, and then that glucose, which I always abbreviate as G, now can migrate into the cell, right? Be stored as glycogen, or if we need it for metabolism, right? The other cell, metabolic pathway, the other G, we had, glycolysis. We can make it, which we call glycogen synthesis, right? We can break it down, but we can also use it for energy. But the glucose is now getting out of the blood and then into the cell. Okay? In this instance, right, with insulin resistance, what we're saying is insulin's still binding onto the insulin receptor, but what's happening is we're not getting any insulin-mediated signaling, right? So that phosphorylation event, which was previously occurring, is no longer occurring. We don't get any of this stuff. We don't get any of this. We don't get any of this docking, right? So now glucose is not entering into the cell, and it's now stuck in the blood, right? That's the issue with most of the skeletal muscle in particular, right? That's what we mean by insulin resistance. Insulin resistance is that issue, okay? Insulin resistance, contributing to hyperglycemia, right? What's interesting is, in cases of type 2 diabetes, right, what we see is this, I think we alluded to this term last time. What happens is that we have a meal, number one here. The pancreas responds, secretes insulin. Insulin binds onto the receptor, but nothing happens, right? So that glucose that was supposed to be going into, say, the skeletal muscle circulates back around and shows up now again at the pancreas again. And the pancreas says, what are you still doing here? I gave you insulin, right? I guess something happens. So what the pancreas responds with is, okay, I guess we need more. So it starts to secrete out more insulin and more insulin and more insulin until ultimately there's a response. Ultimately, this insulin will find a receptor that will allow and bypass and allow ultimately the AKT, right, to be phosphorylated and the glucose. But it takes more and more and more insulin to try to figure out what I refer to as the broken lock, right? The lock's starting to get jammed up, right? Insulin has to go searching around to find a lock that it can open to allow glucose to enter the cell, right? In the case of type 1 diabetes, we're missing the key, right? We don't have a key, the key being insulin. In this case, we have a broken lock. There's sand getting in the lock. We can't unlock it very well. So insulin's searching around to try to find a lock. In this case, it's insulin-mediated signaling that's still working somewhere in the cell, right? There's maybe a pathway to allow it to happen to unlock it, but it takes a while, right? So that's what we say when we say developing insulin resistance is the pancreas starts secreting more and more and more insulin. So the patient with type 2 diabetes not only winds up with chronic hyperglycemia, they wind up with chronic hyperinsulin. We used this term last time, insulinemia, right? hyperinsulinemia. So they're walking around well after you have a meal and the expected response. And we'll talk about this more in detail with the diagnostics and so forth. But after you eat a standard meal, lunch, dinner, within about an hour or two, that glucose is out of the blood and into storage, right? In an individual with insulin resistance, that now hovers around for hours upon hours upon hours until the next meal. And then the next meal comes and they still can't clear it out. So throughout the day, they're chronically hyperglycemic. And because the pancreas is having to work really hard to try to deliver more and more insulin to try to find available locks that are still working, you wind up with chronic hyperinsulinemia, right? So and obviously that wouldn't be the case with type 1 diabetes because type 1 diabetes there's no insulin. So that's one of the distinguishments between type 1 and type 2 is that in type 2 diabetes, lots of insulin, hyperinsulinemia, right? And in type 1, there is no insulin, right? There's just hyperglycemia, okay? So there's a distinguishment there, all right? So that's sort of the beginnings of the etiology of insulin resistance, right? So you might be saying to yourself, all right, I kind of get that. All right, there's the broken locks, meaning the insulin-mediated cell signaling is not working. We can't unlock the lock. Glucose can't get in, right? Glucose transporter can't get to the membrane. We need more and more insulin. Okay, I get it, okay? But if you're really curious, and I've had some students write me who would say, I really like physiology. For this is really for you now, right? If you really like physiology, maybe we'll touch on a little bit more detail about, you might be thinking now, okay, I get that, but how? What's going on? Why does this lock get broken? What is the underlying cause of this issue, right? And the underlying cause of the issue, right? If we get a little bit more detail into the etiology or cause, just to kind of touch on it, really, the causative nature, the etiology, what the underpinning is, right, is we know from type 1 it's an autoimmune condition, right, where the immune system gets, the way the term is, annoyed, right, by itself and starts to attack its own pancreas, right, gets agitated and starts to break your own beta cells down. In the case of type 2 diabetes, you know my Venn diagrams, I love my drawings, right? So really type 2 diabetes, when you look at the etiology, kind of the causative nature of it, right? When we look at it, it's really kind of a convergence of kind of three major causative issues, right? That being the overweight or obesity issue, right? So carrying excess body fat, and we'll talk about that in a little more detail in a second, but carrying excess body fat we know is really deleterious to physiology and really a contributing cause to type 2 diabetes, right? Another one, which is, close to my heart here and overlapping, is physical activity, and really more specifically physical inactivity. All right, so what's called sedentarianism, right? Where you're more sedentary, right? So what we're saying is, there's the term, when we become sedentary, when we lack movement, right? That's a contributing cause as well. Obviously, it contributes to the accumulation of body fat when we're not burning calories, right? So this has an overlap with overweight and obesity. Obviously, obesity issue, obviously nutritional and diet plays a role, but there is an overlap between these factors, right? And then to a smaller degree, right, maybe Johns Hopkins medical and public health departments have kind of estimated that the family history or maybe genetics component is it's usually less than 10%. The two major factors that contribute to are these two factors, right? That being obesity, overweight, physical inactivity, and to a lesser degree, the genetic component. Maybe there's a family history. If your relatives have a history of it, maybe there's a greater chance for you to have type 2 diabetes. But it's far more in the quasi-controllable lifestyle element of physical activity and body weight management are the two major facets that we need to attack for type 2 diabetes, and less so on the genetic element, is what the data is kind of suggesting to us. Okay? So, where am I time-wise? A little bit longer than I want, but I'm loquacious is the word. There's a good GRE word for it. I like to talk a lot. So I'm going to just give you a little bit more information. Okay, all right, so how does this overweight, obesity, excessive body fat, we know if we're physically inactive, we have a greater tendency to accumulate body fat, but for those who really like physiology, how does that work? How does that contribute to insulin resistance? So you all know me by now, you know what I'm going to draw, right? The arc. You love my arcs, right? So here's another little arc, right? But what we have here, it's not a great color to draw with, but I think it's suitable because this is literally what the color is, right? I'm going to draw this kind of excessive adiposity as yellow circles. These are be adipocytes, right? So we get an accumulation of body fat, right? So this yellow drawing over here would be indicative of an increase in adipocyte number, right? Adipocytes meaning your fat cells, meaning you're making more fat cells to store more of that excessive energy in terms of sugar load and whatnot, but that calorie load, you're storing them as triglycerides. So the adipocytes store energy as excessive energy as triglyceride, right? Triglyceride is how you store your body fat in an adipocyte. All right, triglyceride, okay? So increased fat storage, right? And we see that from, a variety of different areas. We see it in subcutaneous, right? Just beneath the skin. We see it in the visceral. Visceral is a term meaning surrounding the organs and bathing the organs. So not just beneath the skin, which is what you can pinch, the proverbial love handle, right? Those types of things, but those would be more the visual evidence of increased body fat would be in the subcutaneous region, right? Visceral means surrounding and bathing the organs, like your liver, your small intestine, large intestine, all in your core, right? In the abdominal cavity would be visceral, right? And then the last place we'll store it is intracellular, right? You can actually store it inside of muscle tissue, which contribute to dysfunction. If you store it excessively in the liver, we call that fatty liver disease, or known as steatosis. Right? Steatosis, steatosis, fatty liver disease, right? Fatty liver disease, if it's stored inside of the cells, the hepatocytes of the liver, right? So that's steatosis. That's the word I had tried to write down there. Steatosis, steatosis, fatty liver condition, right? What happens now is we start to store more and more body fat. The prevailing thought seems to be a trigger for the immune system, right? So what happens is we start to maybe, number one, store more body fat in any of these compartments. The immune system seems to respond. We see an increase in the immune activity, we'll kind of title it, right? Most notably, a type of cell known as your macrophage. And that'll circle back for cardiovascular. So your macrophage, your large eaters, macrophage, your macrophages, or if you're fancy sounding, macrophage, right? Large eaters, right? These are one of the big cells in the immune system. These will now start to invade into, I'm going to kind of draw it as blue, right? So these macrophages will begin to come in. It's almost as if the immune system sees this excessive body fat as an invading pathogen and starts to try to eliminate it. So it'll send all these macrophages into the immune system, into the adipocytes, and try to dissolve or digest the excessive body fat, almost as if it's a pathogen, right? What then happens is these activated immune cells, as you know from your physiology, will secrete a whole bunch of different immune products, right? These immune products, these signaling molecules, I I don't want blue, I want black. I want black. Yes, black, right? So what happens in our third step, right here, is we see an increase in these communication molecules of the immune system known as cytokines. These will be the hormones, so it fits into our discussion of endocrine. Cytokines are the hormones of the immune system. They're designed to recruit and bring in and activate other immune cells. So these activated and irritated macrophages that are in the adipocyte locations, right, will begin to secrete out all these cytokines into the blood to try to further amplify and activate more immune response, right? This is commonly referred to in the literature as either systemic inflammation or more kind of colloquially, as you hear it as kind of a more dramatic as the cytokine storm. The cytokine storm. Like the bloodstream is supercharged by the immune system, right? So it's almost as if an individual living with and trying to manage type 2 diabetes, if you took a blood sample, it's almost as if it appears they're fighting off an infection because of this systemic inflammation and or this other term, the cytokine storm. It sounds very dramatic, like it's a movie, right? So that's what's going on in the blood as we see this supercharged immune environment for individuals living with type 2 diabetes, excessive body fat, overweight issues, okay? What that seems to happen is these cytokines will bind onto, maybe I'll change the shape of my receptor, right? These cytokines, for the purposes of this class, we don't need to know the specifics, right? I won't test you on them, but you might see molecules like TNF alpha or various interleukins, ILs, interleukins. These will be cytokine examples, right? That'll bind on to an inflammatory receptor right on the surface of the cell. And what will happen is we'll get activation of inflammatory signaling. Right? So different molecules other than AKT, there's a whole different array of communication molecules inside the cells that'll become activated when these cytokines bind onto receptors on the surface of the cell. So what happens is, maybe I'll change my color here, is we had insulin binding onto the insulin receptor, right? We had our insulin-mediated signaling, right, going to AKT, right, that whole thing, right, this inflammatory signaling that gets activated in the presence, this seems to be the causative nature that causes the turning off of this. This is the jamming of the lock. So one of the causative natures of insulin resistance seems to be adiposity tied into systemic inflammation, which then activates inflammatory signaling in these target organs, that being the skeletal muscle. So the skeletal muscle has difficulty then starting to pull glucose into the cell, right? The major job of insulin in the liver is to tell the liver hey, a liver, remember we talked about the liver can secrete glucose into the blood? The major job of insulin in the liver is not necessarily to tell it to store the glucose. Its major job is to tell the liver what to do with the glucose. And in particular, it's telling the liver, don't do glycogenolysis. The major job you have to keep in mind for insulin is to store energy and not secrete it. The insulin is telling the cells we have more than enough energy in the blood. Don't put any more energy molecules like glucose into the blood. So the major job of insulin on the skeletal muscle, right? For skeletal muscle, insulin's role for skeletal muscle is to store glucose, right? So insulin's job, let me write that a little bit more legibly for you. I apologize. I get excited and I speed up, right? So insulin's role in the skeletal muscle is to store glucose. Once again, skeletal muscle is a selfish consumer. 90% of all your sugar is stored in muscle as glycogen, right? In the liver, the major job of insulin is to tell the major job of insulin on the liver is to tell the liver to stop secreting glucose, right? Don't do glycogenolysis. Don't do gluconeogenesis. We have more than enough glucose in the blood. Stop it. Keep it in there. Once it's showing up in the liver, store it. Don't secrete it, right? In the adipocyte, the major job of insulin is to use the glucose to make fat, right? To store the glucose as triglyceride, and also stop secreting fat into the blood. So store the glucose as fat, and then don't liberate any more energy into the blood. The major storage energy molecule in a fat cell is triglyceride. We don't want to do, if we know this other metabolic pathway known as lipolysis, we don't want to break down triglyceride and release it into the blood, right? We have more than enough energy in the blood. Stop putting energy out there. Store everything. Everything's fine, right? Energy balance is fine. When we have insulin resistance now, skeletal muscle can't pull it in, can't pull the glucose in. The liver continues to put glucose into the blood, which further amplifies the hyperglycemia problem, right? And the adipocyte can't pull fat in, can't pull glucose in and make fat. In actuality, what happens is the adipocyte loses its communication to the blood through insulin and starts to put fat into the blood. So now you can hopefully see from this connection between diabetes and cardiovascular disease, because cardiovascular disease is largely about too much fat in the blood, right? Cholesterol, triglycerides, right? That's the major underpinning and etiology for cardiovascular disease, is a fatty-based bloodstream, right? In part, it's caused by insulin resistance in the adipocyte. The adipocyte A can't pull the glucose in, so we have this candy coating in the blood. And also, insulin can't tell the adipocyte to stop secreting fat into the blood, so it amplifies. We see an amplification in insulin resistance with lipolysis, right? The breakdown of fat, right? So the fat cell says, I guess there's a need for more energy in other cells of the body, so I'll continue to release triglyceride and fat molecules into the blood, and now we wind up with hypercholesterolemia, high levels of triglyceride, a supercharged bloodstream now that's just ripe for atherosclerosis and plaque formation and clogging of the arteries through this candy coating with sugar. We have an inflammatory supercharged environment. We have a lot of fat in the blood because there's adipocyte dysfunction, right? We have the liver now that's pumping out glucose because it loses its ability to communicate with insulin. And now we have this blood-borne environment that's just a mess, right? And it's contributing to degradation of a lot of systems. In another video here, we'll talk about the complications, the health degradation that occurs with this blood environment that now has a lot of sugar, a lot of fat in it, and all the problems that then arise thereafter, okay? So I know that was a lot of information. Welcome to college. I try to elevate and enhance your experience from anatomy and physiology, right? For those who love physiology, right? Maybe this is really up your alley. If not, then just get through it. Make sure you understand this interconnection and the roles of insulin. In our case, type 2 diabetes, it's all about insulin resistance, right? Hyperglycemia caused by this broken insulin-mediated signaling, the jamming of the lock. Okay? I think we'll call it there. I'm a little longer than I wanted to be. I apologize. I get excited. What's that word again? I'm loquacious. I like to talk about this information. Nice thing it's recorded. You can slow things down. So if I'm speaking a little bit quickly there, I apologize. But you can go back and watch the video. Certainly reach out to me if there's any questions. Okay? So keep up the great work. All right. Thank you, everybody.